Having a baby can be one of the biggest and happiest events in a woman's life. While life with a new baby can be thrilling and rewarding, it can also be stressful at times. Many physical and emotional changes happen to a woman during pregnancy and after she gives birth. These changes can leave new mothers feeling sad, anxious, afraid, or confused. For many women, these feelings dissolve quickly. But when these feelings persist or worsen, then a woman may be experiencing postpartum depression. Postpartum depression, also known as PPD, is a serious condition that requires medical treatment. So today, we are going to speak with a mental health specialist about postpartum depression to help you or someone you know that may be suffering. Today's guest is a clinical faculty member at George Washington University Department of Psychiatry. She is a trained reproductive psychiatrist with extensive experience working with women's health issues, including mental health treatment prior to conception, during pregnancy, and postpartum. She's a mother of 2 young boys and also maintaining a private practice in Centerville, Virginia. Please welcome to the show, Dr. Beverly Reader. Thank you for coming on to the show, Dr. Reader.
Hi, thanks for having me.
Well, before we get started, I just wanted to say, I know that you're 8 weeks postpartum.
I am.
And you look fabulous.
Thank you. I never get tired of hearing that, so thanks a getting great.
Well, getting into the topic here, we're talking postpartum depression. What is postpartum depression?
So, people speak about the baby blues, postpartum depression. In the news, we hear scary stories about women who are psychotic postpartum and harm their babies or harm themselves. It's really easiest to think about it all along a continuum.
Okay.
So, postpartum, women experience dramatic hormone shifts. Within 48 hours after birth, estrogen and progesterone levels fall dramatically. And we know that these gonadal hormones modulate the same neurotransmitters that regulate mood. So the baby blues occurs in about 85% of women.
Okay.
And so to say it's even a psychiatric issue is it's really actually normal. But what it is it's just within a few days of birth, and it remits within a couple weeks.
Okay.
And it's not sadness, usually. It's lability in mood, meaning sort of up and down in your mood, irritability, a little bit of anxiety, typical stuff that you might see with like a new, little bit anxious mom.
Okay.
But it's not sadness, and like I said, it remits spontaneously and quickly without any treatment within a couple weeks.
Okay.
Postpartum depression would be the next sort of step along that continuum.
Okay.
And that's where those symptoms don't remit within a couple weeks, but actually progress and worsen,
Okay.
and start to affect the mother's ability to function and care for her baby.
Okay.
So baby blues doesn't affect a mother's ability to care for her child, whereas when people start to become depressed, it does.
Okay.
They experience symptoms most typically of severe insomnia, so even though they're exhausted, when the baby's sleeping and it's their turn to sleep, they just can't fall asleep.
Okay.
Appetite changes. Most often they stop eating, aren't eating very much. That's usually what happens, although some women will just eat excessively.
Okay.
Tearful often. Extreme anxiety, more than often than I see in usual depression.
Okay.
And a lot of anxious thoughts focused around the baby. So
Okay.
some hypochondriasis type stuff about their own health, about the baby's health. And the other unique component to it is the obsessive thinking that's involved.
Okay.
Intrusive thoughts, meaning the mothers don't want to be thinking them and don't mean to mean them, but they intrude into their mind about harming the baby or
Okay.
harming themselves.
Okay.
Again, they're intrusive, and it usually scares the mothers, and they don't want to admit they're having such thoughts because it's not really how they feel. But those are sort of the classic depression symptoms that start to emerge.
Okay.
And they emerge after that 2-week part. Anywhere, I say they peak usually clinically between 4 and 8 weeks.
Okay.
So most often, I'd say women say like around the 6-week mark is where they're truly feeling symptoms, although they don't always present for treatment necessarily at that point, because they are still convinced on some level it's the baby blues. They don't want to admit that they're having these feelings because it's supposed to be a joyful and happy time.
Right.
And they just assume it'll pass, or it has something to do with the fact that they're not sleeping enough or eating right or those kinds of things. So there's a stigma with admitting it.
Okay.
And then the next part of the continuum would be the severe form, which is where the symptoms progress into someone being manic or psychotic. Very, 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 very rare. 1 or 2 postpartum women out of 1,000 experience that level or severity of symptoms. It usually happens very quickly. Not at that 6 to 8 week mark, more commonly early on in the first few weeks postpartum. And it's very obvious to everyone around the mother. It's delusional thinking, auditory hallucinations, bizarre, erratic, disorganized behavior. And the only one who isn't really aware of what's going on would be the mother herself. So that's where the cases of harm to infant or mother are of concern. And that's a psychiatric emergency that requires hospitalization. But again, so rare. I mean, to me, not as rare because I have a skewed population. But in the general population, like I said, 1 to 2 out of 1,000. So more commonly, about 20% of women. Statistics are anywhere from 10, 15, some literature up to 20% of women postpartum go on to experience postpartum depression.
So we kind of identified the 3 stages. We have the baby blues, then we have postpartum depression, and then from there it's the postpartum.
It would be a psychotic.
The psychotic, so focusing on trying to differentiate between baby blues and postpartum, it's pretty clear within the first couple days up to like about 4 weeks or so.
2 weeks is the definitive sort of timeline from a diagnostic standpoint that we use, that symptoms then sort of meet criteria for a major depressive episode. So baby blues should remit within a couple weeks. If they are continuing on, that's when you want to start looking at a further evaluation or assessment of, is this actually depression that's going on that warrants treatment.
So who's at risk of postpartum depression?
Anyone and everyone, really. I mean, it doesn't matter socioeconomic class, you know, there's not any targeted area of the population or race or anything like that. However, there are women that are at higher risk than others. So if you've had a previous history of depression ever in your life, depression during pregnancy, obviously, very high. A previous episode of postpartum depression with a previous pregnancy. And then marital discord and a lack of social support.
So from the outside looking in, how would you be able to judge or tell if someone is experiencing some level of postpartum depression?
Usually partners notice it. A lot of my patients come to me because their husbands call. And so typically what people, what friends and family start to notice is an inability or an inadequacy of caring for the baby, or a lack of interest in caring for the baby. So, you know, when a woman is very depressed, she's crying a lot, she's very anxious, she's not sleeping, she's not functioning very well to take care of herself, let alone the high needs that a newborn has. And so it starts to fall on the partner, it starts to fall on the mother-in-law who's visiting. And so typically the ones closest to her usually are the ones that start to notice. Mothers don't typically notice. Although later when they're interviewed, they will start to admit, yes, I'm crying all the time. Yes, I actually am thinking of hurting my baby, although I would never do it. You know, they're just, they're sort of, I think there's an element of denying. They don't want what's happening to them to be happening to them. So it's usually partners that, or close family members that notice. And that's what they notice. Just, it's not the same person that, you know, they know.
That they're used to.
And they're usually very anxious, irritable, crying all the time. And then, like I said, she doesn't seem interested in the baby. She doesn't seem able to care for the baby the way, you know, I would expect, those kinds of things.
So once a woman has realized that she's experiencing some level of depression, what's the recommended action plan?
Call for help. So there's a lot of resources available. And, you know, women have their 6-week postpartum check, and you can mention it to your obstetrician. Unfortunately, many obstetricians don't ask, so it's only when the patient goes in and sort of breaks down in tears that they're then given a referral. I would say a psychiatrist is the best place to start, and certainly if you can see someone who specializes. There's a website, postpartum.net, which is a resource for postpartum perinatal specialists in the Northern Virginia area, psychiatrists, social workers, therapists, psychologists, support groups. So looking on there is a good place to start. Asking your obstetrician is a good place to start. But as quickly as possible, seeking medical help. So whether that be with your OB first if you're comfortable, or going straight to a psychiatrist. Or some women go first to a psychologist and talk there, and then a psychologist or any sort of therapist, whether it be a counselor, social worker, or a licensed clinical psychologist, can then make a referral. You know, I think this is a little more serious than just therapy, and medication might be warranted, and they can make a referral to a psychiatrist.
So what kind of treatment should one expect once they've reached out for help?
Usually it's a combination of things. I mean, it depends on the severity of what symptoms are presenting. Some women come to me and really what they need is just to get a little bit of sleep and some better communication with their spouse. So parent counseling is something I'll send them to.
Nice.
And maybe a sleep aid and check in with them in a couple weeks and see how things are going. That would be like the mildest version. And then in a moderate case, start use of an antidepressant, maybe other medications that more quickly alleviate anxiety and gets a woman sleeping. And as well as therapy if it's indicated. Pregnancy and postpartum brings up a lot of issues for a woman. You know, relationship with their own mother. Now I'm a mother, role change, relationship with their partner, that change. So there's a lot of complex psychodynamic issues that come up to varying degrees. So referral for addressing those if appropriate. And then certainly you always, and I should have mentioned this first, ruling out any medical cause, because there are some medical causes postpartum that lead to depression and anxiety. So you want to make sure those are addressed first. So I always check laboratory work and make sure that there aren't any thyroid abnormalities or pituitary type abnormalities or blood count abnormalities, anything that would cause some of these symptom overlap. Yeah.
Interesting. So for the cases where medication is prescribed for women that are experiencing postpartum depression, for women that are nursing, how does that affect their ability to nurse their infants?
In most cases, it's fine. I give medication to breastfeeding women all the time. So what you want to keep in mind with, I mean, there are certain, there's a certain kind of handful of medications we use most commonly in breastfeeding that have been studied, that are more well studied than others. And what most of the literature supports is that minimal amounts are excreted in breast milk, and that when we test the serum, meaning if a mother is taking Zoloft, for example, she breastfeeds, and then you draw the blood of the baby shortly after the breastfeed, the Zoloft is undetectable in the baby's blood. So even though it's detectable in the breast milk, and we do know some amount is getting in there, the quantity seems to be, for most medications, at least the ones we prescribe for breastfeeding mothers, in minute enough quantities that it doesn't seem to be something that we're very concerned about with the infant.
So because the quantity is not substantial enough to be able to detect in the infant, is there any risk associated with the medicine and the infants?
The risk is really minimal. I mean, there aren't any, and let's not be clear, it's not all medications that aren't, I mean, there are some that are detectable to higher levels in the milk, therefore to higher levels in the infant.
Baby?
So we avoid those. But then there are others that are the opposite, and those are the ones that clinically in practice we will use. The risk is minimal. I mean, the risk is minimal. To put it, sort of to give some perspective on it, certainly breastfeeding, the exposure to the baby is very small. But we treat women in pregnancy with these medications. And obviously in pregnancy, everything crosses the placenta.
Right.
So the baby is exposed to a much greater degree. Research studies have been done, one in particular, that followed children who were exposed to antidepressants in utero 7 years out, which is pretty good data. It's hard to follow a cohort of children 7 years. And they were assessed at different intervals on behavior, temperament, mood, reactivity, activity level, IQ, and there was no difference in the children that were exposed to antidepressants versus control children that were not.
Interesting.
So, you know, we can extrapolate from that data that, you know, if the risk of cognition or behavioral or developmental risk to children exposed in utero seems to be negligible, then the same would be true for the same class of subgroup of medications we're using for babies exposed via breastfeeding, because they're exposed to so much less.
Interesting, and it actually takes me to my next question. There's been concern about these medications linking to things like autism or birth defects. And there's been, you know, a few commercials floating around inquiring about women that have taken these medications while pregnant and after. And some are pretty concerned about either their child having a birth defect or future pregnancies. So what would be your expert advice on that?
I haven't seen the commercials, thankfully, although I have heard of them. So to address the risk of medication in pregnancy, so about 20% of women experience depression in pregnancy. And you know, you just have to assess the degree of severity of the depression. What may not be well known to people is there are clear physiological risks prenatally to the developing fetus for untreated depression and anxiety. So the risk of medication exposure needs to be weighed against the risk of untreated depression and anxiety prenatally as well. It's not just behavioral risk, meaning mothers who are depressed or anxious get poor prenatal care, use substances, do other behavioral things that put the fetus at risk, but there are physiological risks as well. I mean, I won't get into them here, but that's been well established. So, so there's always, in everything in medicine that we do, it's a risk-benefit ratio, and so that's what you're weighing. And so the risk with, and there's sort of three things you look at in terms of risk of medication with pregnancy exposure. The risk of malformations. So birth defects, the risk of the baby after birth in terms of withdrawal or any symptoms they may have immediately after birth and how risky that is to the baby. And then the third thing would be the risk long-term down the road, 7, 10, 20 years later when the child's grown. So I already briefly addressed the last risk, which, you know, thus far we don't seem to see literature that supports that there is a long-term cognitive or behavioral or developmental risk to children exposed to antidepressants. And then risk at birth, there's some conflicting studies of mild withdrawal symptoms at birth. Again, the data is interpreted very cautiously because they're conflicting. So some say yes, some say no. And the data is very small when when it is saying yes. It's in a small percentage of infants, and it is not something that has long-term effects. So that's the most I'll go into it here without saying specifics about what those risks are at birth. And then backing up to malformations, a lot of studies have been done where cohorts of children in the thousands have been looked at. And there does not seem to be a causally related malformation risk with the group of medications that we use. Like I said, there are some that are different, but the ones that we use clinically. And so if there are some studies that have shown some, you know, because a lot of this data is very conflicting. We can't do double-blind trials with women, placebo-controlled trials for pregnant women, so a lot of this data is extrapolated in a variety of different ways that isn't always as accurate as other studies can be. So you sort of have to kind of take it all together and assess it critically, et cetera. But the order of birth defects associated with a woman who's taken a medication is on the order, in some studies, of about 1%.
Okay.
But bear in mind that no pregnancy is risk-free, and whenever we get pregnant, at baseline in the normal population, the risk of any birth defect is 3%. So the risk, so that's sort of want to keep in mind the relative risk, and that's what I point out to women is there is no risk-free pregnancy, 3% chance just by getting pregnant. The risk of taking this medication, potentially 1%. But again, as I mentioned, the risk of women who don't treat their illness. So weighing all of those things is what you have to consider. In terms of the autism study, that's very, very new data that just came out. I've read the study carefully. They looked at about 300 babies that were born with autism spectrum disorder, meaning anywhere from mild, moderate to severe autism, and they compared that with healthy controls. And then they looked at antidepressant exposure of the two groups.
Okay.
And the group that, there was a difference of 3% risk in the ones that were not exposed, and a 6% risk in the ones that were exposed,
Okay.
Which is statistically significant. However, they didn't account for maternal illness or symptoms during pregnancy. And as I mentioned, the physiological things that go on with a woman who is untreated, depressed, and anxious during pregnancy, and the genetics that go with that and the family history of psychiatric illness are also known to contribute to the development of autism-like spectrum disorders. Yes. So you can't, the study does not enable you to ferret out, is it the medications causing that increase, or is it the underlying cause for the reason the women were taking the medications?
The medication.
So because you can't ferret that out, we don't know.
Okay.
And so it's just more research needs to be done. So at this time, there is no way to say there's a causal identification with the medication use with autism.
Interesting. So once a woman has been diagnosed and she started taking the antidepressant medication, are there any things that she should avoid while she's in the recovery mode?
No, the biggest thing I want women when I start treating them is to experience some relief from how they're feeling. So I want to normalize how they're feeling, and I want to get them feeling better, get them support, and get them relief from their symptoms right away. So whatever makes them feel good, I tell them to do it. So usually it means incorporating the spouse into working out. Most women need to have a plan of sleep. Most women have inadequate social support that experience postpartum depression. That is a very, very common thing that I see. So it's implementing social support, however that might be. If family is available, if not, using some of the resources available that you can see through postpartum.net about hiring doulas or night nurses or whatever it needs to be done. Sharing it with family members, sharing it with your spouse. So getting support so mom can sleep, mom can rest. If breastfeeding is an issue, working around modifying that to some degree so that the labor can be shared. But exercise, seeing friends and family, support groups. I mean, the only thing I just say is let's start doing things that start getting you feeling better. So there isn't anything to really avoid other than alcohol, drugs, the same things I would tell anyone in treatment for something to avoid. So.
Okay, and we're running out of time, but I want to make sure that we wrap up and we get a lot of concerns that a lot of new moms are concerned about. Aside from, you mentioned about family support and friends. That's obviously a big part of the puzzle. What are some things that family members and friends can do to help a mom that's experiencing postpartum depression?
A lot of moms seem to be really hesitant to ask. There seems to be a message in our culture of superwomen, that we can do it all and we shouldn't need to ask for help. So I think if as much as family members and friends can volunteer, or even be a little pushy about volunteering, and especially offering to give breaks so mom can get some rest.
Okay.
That's probably the biggest. But then being supportive emotionally, and decisions mom needs to make about taking medication, supporting that.
Okay.
Even if that for you personally is something you aren't sure if you agree with, supporting her decision.
Okay.
If she decides to stop breastfeeding because it's too stressful for her, supporting that decision. So just being as supportive as possible of what steps the mom is taking to get herself feeling better.
Okay, awesome. Well, this is such a large topic, and unfortunately, we're out of time to really get into the meat and potatoes of things. But please let the moms know if there's any resources out there that would be helpful to them in trying to seek help. Yes,
there are several really good websites. So I mentioned postpartum.net. That's a national website. There's a chapter in every state that can provide resources of all different categories for women to access. So that's a great one. There's depressionafterdelivery.com, another good website. Womensmentalhealth.org is the Mass General Harvard related website with a lot of good medical information, blogs, and educational information that I think is good for clinicians, but it also is good for family and patients to take a look at as well.
Okay.
And pacemoms.org is another good organization locally that has a lot of educational resources and groups, et cetera.
Awesome. And if anyone's interested in reaching you, what's the best way to get in touch with you?
My private practice is in Centerville, and our website is fairfaxmentalhealth.com.
Okay. And that's a wrap. Thanks for tuning in to Smart Mom. Hopefully today you learned something that would help you or someone you know. If you'd like more information about the topic, please visit the website at www.smartmom.tv. Thanks again for tuning in. Until next time, God bless.